Welcome back to the Gillett Health podcast, where we give you tools to develop a balanced approach to health. I'm Dr. Kyle Gillett.
And I'm Dr. Taylor Martin. Happy to be here.
Yeah, great to have you. It is nice. I was going to say this is our guest, Dr. Taylor Martin, but I guess you're not a guest because you were our colleague here at Gillett Health.
Yeah, excited to be seeing patients now in Los Angeles and in the whole California area.
So some of our listeners might be familiar with you because you've done podcasts with James before. But for those who don't know, how about a quick intro, I guess, why you're in this room chatting with me right now?
All right. Well, I'm a preventive medicine physician. I did my training at Johns Hopkins, where I also did a master's of public health. I'm really passionate about providing high quality care to patients. And that's why I got connected with Gillett Health.
Perfect. A common question about preventive medicine specialty is, I guess, other than develop treatment algorithms so that people can be algorithm robots, what does preventive medicine do? Why would a health optimization clinic like this even care about preventive medicine? Because we just want to do fancy stuff like peptides, right?
Not exactly. Preventive medicine, I think, is the foundation for health optimization. I think of preventive medicine as being focused on preventing disease from occurring. And so I think about that in the three buckets of prevention. So primary prevention, preventing disease from happening in the first place. We can use a colon cancer as an example. So eating high amounts of fiber, decreasing the alcohol you drink, stuff like that. Secondary prevention, which would be identifying the disease as early as possible. So cancer screening, getting a colonoscopy or a FIT test. You could talk to your doctor about which one is best for you. And then tertiary prevention, preventing that disease from causing end organ failure and ultimately causing mortality and death. So for colon cancer, it would be sending you to the surgeon to get a resection of that cancer.
That's a good summary. Maybe not as sexy to talk about as things like hormone optimization or fertility or peptides, but certainly necessary. One analogy we like to make is before you put a turbocharger or nitrous on your supercar, then you probably want to make sure that you rotate the tires and get the oil changed and interventions like that.
Absolutely, yeah. I don't think you'd be wanting to add a lot of those interventions on if you weren't covering kind of the foundation or the basics. If you have your testosterone optimized, but you're not taking care of your cardiovascular health or your metabolic health, you're still going to have a poor body composition and a hard time later in life. So it's really important to combine those together.
Certainly. And that's, I guess, a good segue to say, you work at a health optimization clinic completely outside what you would consider the traditional medicine sphere. And then you also work in academia. You've been at Johns Hopkins. You've been at UCLA, well-credentialed academic centers with good repute. I guess, how do you find the balance between working in what you would think is the antithesis of each other? And do you enjoy one more than another? Like, where's the balance there?
I enjoy both equally so, and I think my experience on either one of them benefits the other. I'm really thankful to be part of Gillett Health and be able to do the type of care that we provide now. That's kind of one frustration that I've ran into in the large academic systems is everything is constrained by insurance as well as quality metrics. Insurance is moving into a value-based care system where they're going to be paying for outcomes. But right now, that's not the case. They're right now paying for process measures. So how often are you screening for colon cancer? How often are you getting your mammogram? Stuff like that. And so that is all focused on kind of cookie cutter ways of providing care. And I think that's good from a population aspect. But when it comes to an individual, it's a little frustrating when I'm trying to provide the best care to that individual patient in front of me. That's why I really enjoyed being able to kind of get out of that system and work with Gillett Health to provide really high quality care that's really focused on the patient and their medical history and their priorities.
When people hear this buzzword outcomes, what does that mean? Because, there's some outcomes that you're looking at in literature, like MACE. MACE is probably a decent outcome to look at for a lot of individuals. It always concerns me a little bit, and perhaps it should concern the public as well. What outcomes will be looked at and over what period of time? For example, are they looking at 10 years or 30 years? Because I think about the classic example of, or classic examples of ASCVD prevention and cancer prevention. And if you're doing something to increase the incidence of this, let's just use, utilizing a lot of synthetic androgens for decades and its cardiovascular risk outcome, you might not have any signs or symptoms of that for 3 or 4 decades. Or let's say you're using BPC 157 continuously, again, for 3 decades. If you use it from age 25 to age 55, you're probably not going to develop cancer in that time. You might, but how do you look at an outcome that might be insidious in onset or not be seen for many decades?
Well, I think it is bringing up a good point. It's really important to use short and long-term outcomes and use broad outcomes as well as very narrow organ-specific outcomes, and using those together to get a really good perspective on the intervention. So, one of my favorite outcomes to look at is all-cause mortality, which is really the heavy hitter. If you can provide an intervention that changes the all-cause mortality, so giving you a statin that might decrease your all-cause mortality, that's decreasing your risk of even dying from a car crash, things that are completely unrelated. So if it can decrease your all-cause mortality, that's a pretty good sign it's going to be efficacious for improving your lifespan and your health span. I would also pair that though with probably multiple cardiovascular outcomes, because likely if it has an impact on all-cause mortality, it'll have an even higher outcome on impact on cardiovascular outcome, which is where that statin majority is working.
Yeah. I had a friend, and I can't remember which one it was. I believe it was an MSL that described all-cause mortality as the holy grail of outcomes-based care.
Yeah, it certainly is, and it's really hard to decrease your all-cause mortality. If you have a statistically significant impact on your all-cause mortality, that's a pretty big headline and draws a lot of eyes.
Yeah, I guess that's a good segue into how preventive medicine interacts with family medicine and obesity medicine. People are pretty familiar, at least the listeners to this podcast are probably familiar with the obesity epidemic and how the CDC does consider it an epidemic. Often people in the health optimization community say obesity should be treated as a disease, and it actually is considered a disease. And obesity should be considered an epidemic, and the government should, the government. It's like, well, what do you mean by the government? But anyway, not to rabbit trail too much, but the obesity medicine, clinician academic group is exploding. When I was board certified 2.5 or 3 years ago, I believe there was only 3,000 or 4,000 total obesity medicine physicians. And now that number has doubled, even in just a couple of short years. A lot of what I see as preventive medicine overlaps directly with that.
Absolutely, I think so. I think all 3 of those specialties, preventive medicine, family medicine, and obesity medicine, have a lot of overlap. I would say the main differences between preventive medicine and family medicine is, I think, a more rigorous clinical training. Preventive medicine, it focuses on a lot of that, both pediatric and adult populations, and is a primary care specialty, but also incorporates a lot of population health and rigorous statistical training that I don't think you necessarily get in a traditional family medicine training, because you're so focused on just that clinical care. And so I think that's probably the main difference between those two. Also with a bias towards prevention on the preventive medicine side. So obesity medicine is a subspecialty. So after you get a primary specialty in preventive medicine or family medicine or internal medicine, you can subspecialty in obesity medicine. And that gives you further training in how to treat obesity. I think considering obesity as a disease is super important. I think there's been some hesitation in that for a while, because obesity is not the primary cause of death in anybody, but it's associated with many of the leading causes of death. I think in the CDC top 10 causes of death, obesity is highly associated with incidence and worse outcomes. So more likely to die from these diseases in like 6 or 7 of those top 10 diseases. So it's really, really impactful. So I am not board certified in obesity medicine, but where I did my training at Johns Hopkins, we staffed an obesity medicine clinic. I guess I'm curious what getting the subspecialty in obesity medicine provides you more so than just a primary specialty and feeling comfortable with prescribing those medications.
Yeah. A specialty in obesity medicine is pretty similar to a specialty in family medicine. You get out of it what you put into it. Here's a hot take is there's a concept known as a delta, and I think this is in several sports. I believe it's in rock climbing. So different people have a different delta within the same sport. So in the example of rock climbing, and I don't currently rock climb or boulder much right now, but I used to quite often, and a lot of my colleagues do. It seems to be something that a lot of doctors actually share in common. Their love of rock climbing is very, very random. Not sure how close the correlation is, but anyway, different people have a different delta, a way of going about things. And the specific hot take is wide, like mile wide, inch deep specialties that have a large scope of practice, a potentially very large scope of practice, like obesity medicine, like family medicine, like preventive medicine. The potential to set a very high delta or a high starting weight, maybe our audience will appreciate like weightlifting or powerlifting. Different people start at a different standard and do things a different way. They choose different grips. There's different ways of doing things. But in obesity medicine, the specialty itself is actually quite easy to get as long as you put into it just enough to get through the CME and pass the exam. There is obesity medicine programs as well, which are likely of very high quality. I haven't done a specific program itself, just the board certification, but you only get out of it what you put into it. This is pretty well known in family medicine, where you have on average the least qualified and the lowest test scores going into that specialty, despite it being theoretically the highest amount of delta that you can put into it.
Yeah, that makes a lot of sense.
Preventive medicine is kind of the same way. I could see a lot of other preventive medicine physicians really focusing on the informatics and statistics side of things. And clinical medicine is like any other profession. If you don't use it, you lose it.
Exactly. Yeah, your skills atrophy. Yeah, for example, where I did my training at Hopkins, it was very focused on population health and the clinical aspect of preventive medicine. Mm-hmm. And my training was very focused on this obesity training. And where I'm practicing now at a large health system in California, it's much more focused on the lifestyle medicine aspect. And so the training is quite a bit different between those two.
Yeah.
I guess I'm wondering, if I was a patient with obesity, should I seek out a physician with obesity certification, or do you think going to your primary care doctor would be sufficient?
If you do no research into who to go to, it's kind of like thinking about, should I go to a mechanic that specializes in carburetors or just a random mechanic? It's possible that the random mechanic can fix the carburetor, or I guess most cars have an EFI now, but you have a better likelihood of going to a mechanic that at least says something about carburetor in the website. So there is physicians that do treat obesity well that are not board certified. But if that's available in your area, you might as well seek that out. I always tell people it's okay. It's not doctor shopping if you're reading different biographies of doctors on their websites and you think he or she might be a good fit, he or she might be a terrible fit, and then trying a couple that would be a good fit and then finding whichever one is the best fit for you.
That makes sense. And in discussing with my colleagues, I guess one thing I've noticed is that the ones who are more generalist, who aren't obesity certified, they can attack some of the kind of first line and second line treatments. They're pretty familiar with the GLP-1 agonist and maybe Contrave, but they're less familiar with some of the other more specific medications like phentermine or orlistat, and then certainly they don't feel comfortable prescribing off-label medications, where it seems like the obesity medicine trained physicians feel very comfortable prescribing unique off-label medications.
Yeah, they're also less likely to work at an interdisciplinary clinic that has a dietitian or a personal trainer, less likely to get like a deep dive into their sleep, in addition to their diet and exercise. So those are some pros and cons. Certainly, the more severe the pathology, most all pathologies are on a continuum or a spectrum, the more it would be reasonable to seek out an expert in that area.
That makes sense. And the majority of the high quality evidence that I've seen pairs medication with lifestyle changes. So you need a high quality multidisciplinary team to improve your nutrition and your physical activity and your behavior, which are all three as important, maybe more important than that medication aspect. And usually in primary care, they might not have the resources or the time to provide that.
Yeah. That's a great point. We were discussing this yesterday, actually. This might be a good opportunity to discuss it. The change in resting heart rate with GLP-1 receptor agonists and also with the placebo group in the very large studies on GLP-1 receptor agonists. I saw another Hopkins trained physician post about this, Peter Attia, and discussing the increase in resting heart rate if you're on different GLP-1 receptor agonists or combined GLP-1 GIPs. And oddly enough, James dug into this, the placebo group, even though it is a number of thousands, had standard of care diet and exercise intervention. And yet their resting heart rate did not statistically significantly change over a period of 48 weeks, even though when you have monitored, so you know individuals are exercising, a lot of studies show a decrease in resting heart rate, let's say from 75 to 65 of 10, even in a period of 8 to 12 weeks. So that really makes you doubt the validity of, or at least the success of the exercise program. I guess at best, it tells you that if you tell people to diet and exercise, they probably won't.
I think that's the part of the study that I found as a red flag in the methodology, is that they had told the patients to exercise 150 minutes per week, but had given them no explicit instructions on how to do that and what exactly that means, and no monitoring and proof that they were actually doing that. Mm-hmm. Like you're saying, there's a lot of evidence that increasing your physical activity does drop your resting heart rate, especially in the BMI categories that were included in these studies. So it is suspicious, those results.
Mm-hmm. It's also concerning because if you think about one of the main critiques of fast weight loss of any type, not necessarily fat loss, but they really go pretty closely hand in hand. If you lose weight, you're going to lose fat. If you lose fat, you're going to lose weight. Almost with that exception, not quite. But if you're talking about a large volume of weight, 100 pounds, you're concerned about the loss in lean body mass. And exercise is going to be, and specifically resistance training and hormone optimization are going to be some of the most important things for that. So that's one thing to keep in mind when choosing like what specialty a physician to go to. The more specialized the clinic, the more likely you are to have success with actually implementing the diet and exercise plan.
Yeah, absolutely.
Perhaps we can segue into talking about pharmaceutical benefits. On the radio on the way over here, I heard, this was at the local rock station, so I was listening to a little rock on the way into the podcast today, and the radio host, the radio DJ said, there was a new study out. It didn't say who it was by. Would have been nice.
I'd be curious, yeah.
But they said one of the main causes of so they attributed the increasing cost of healthcare in the United States to what's called pharmaceutical benefits managers. And I know that there's a whole bunch of wheeling and dealing, so I thought, what better person to ask than you? What's the deal with these pharmaceutical benefit managers? Are they finding patients the best drugs? Are they middlemen between insurance companies and big pharma? Are they evil gremlins that are stealing all of the profit?
Maybe a mix of all three of those. So the pharmaceutical benefit managers, I'll call them PBMs for short because it's kind of a word salad there. They fit in between the insurance plans and the pharmaceutical companies and the pharmacies. And they kind of help provide the formulary for those insurance plans. So when you're a patient and you have a a commercial insurance plan, which is the majority of patients in the United States, you pay that plan a monthly premium for your health insurance. Those health insurance companies kind of outsource building the formulary. So what medications their patients can get prescribed to them to these PBMs. So they are the ones that build out that formulary for the insurance plans. So they reach out to the pharmacies and discuss with the pharmacies what they're going to have stocked for that insurance plan. They also set up with the pharmaceutical companies to help lobby to get the medications on the plans for the insurance companies. The insurance companies really drive healthcare and what can be provided in these traditional health systems. Not at Gillett Health, we have a much different model here, but in the academic institution I work at, it's really the insurance companies that dictate that. And so the PBMs, they get rebates for every single medication that is purchased from both the pharmacy and the pharmaceutical company. So they are highly incentivized to add on different medications to these formularies based on the amount of rebate that they're getting. And so that certainly drives up cost. Instead of giving that back to the patient, it's going to this middleman group, the PBMs. Another complication with this is when your doctor goes to prescribe you a medication, they might not know what medication is on your formulary. So I might prescribe you rosuvastatin, but if that's not on the formulary, you're going to have to pay out of pocket for that. And there's a bunch of different insurance companies and insurance models that come into a health system. And so unless the physician is really familiar with those, they might not know what is on the formulary. So I've worked to build tools to kind of help you identify which medications are on the formulary and suggest that to the physician so they can provide the lowest cost care to their patient. But these PBMs kind of obscure what exactly is going to be covered on the formularies. So it makes this process very, very difficult. So there is some argument that they can decrease the cost for the patient in the long run because they're working with the pharmaceutical companies and the pharmacies to get a lower cost medication. But there's also good evidence that they drive up cost overall and do not share the cost savings to the patient and instead take that cost savings to themselves.
Interesting. So if you have commercial insurance, it might not be your doctor that's deciding what medication to put you on. It might be a combination of the insurance company and the PBM.
Correct. Your doctor would identify which type of medication you should be on and the class of medication, and then really which medication is going to be able to be given first is going to be dependent on that insurance company. Kind of going back to these GLP-1 agonists, I usually cannot prescribe these as first line to patients. I have to try different medications first, and that I have to document that it failed or the patient did not tolerate it. I have to try another medication and document that they didn't try it. And of course, lifestyle interventions first. And then after all three of those have failed, then I can prescribe the GLP-1 agonist. And that's purely dictated by the insurance company, which is dictated by what the PBM decided.
So it's like healthcare mafia.
That's kind of what it seems like from my perspective.
It makes me so angry. I remember one instance of a patient, and this is partly where the social determinants of health come into play. A patient who did not have excess income to spend on medication, prescribed rosuvastatin, for the record, and we've done podcasts on this before, one of my more favorite statins, and went to the pharmacy. It was not on his plan, but wanted to be a good patient. And now I try to tell patients, by the way, if it's more than $30 or $40 a month, regardless of what it is, do not pick it up. Do not buy it at the pharmacy. The pharmacy will be okay, even if they filled the medicine. Don't even pick up 1 month. Call the doctor's office, message the doctor's office, text our office. Patients text us, patients email us. They can text our main number and we will look into it and we will take care of it. Because it just makes me so mad when a patient picks up a medication like that that's generic for $150 a month, when it's just because probably their PBM happens to get a slightly higher rebate for, let's say, atorvastatin instead of rosuvastatin. So what is the deal with these rebates? Is that just where each supplier of the medication pays that bribe or rebate to the PBM?
Yeah, it goes directly to the PBM. So if the medication cost $100, it might be a $10 repeat. So every single medication that is bought, the PBM is getting that money. So they're incentivized, they're financially incentivized to decide on the formulary based on what medication is going to provide the highest rebate. And one thing what you were saying earlier about encouraging patients to reach out to their physician if the cost is too high, the physicians have very little insight into the end user cost of the medication. There's oftentimes when I prescribe a medication, like you're saying, that's generic, and I'm expecting it to be dollars or maybe cents. And it is for some insurance plans, but it ends up being an exorbitant amount of cost to the patient. And that's, I think, one hopeful improvement we can make over the next decade is really giving physicians the insight into the overall cost that the patient's going to have to pay for before they prescribe. Because I don't think there are really any clinicians who want to prescribe high-cost medications when there's a lower-cost alternative. We want to provide care that patients are going to be able to afford and access. That's kind of one of the more frustrating things is prescribing medications and then the patient not taking those medications. And if it's due to cost, that is on our fault for prescribing something that isn't within their price range. So
even when I've spent time digging through various like Blue Cross Blue Shield's formulary, then the employer will have a plan exclusion just for this certain class of meds, and there's literally no way to look that up. So another example, and I'll just call it how it is some people have heard on a podcast that one GLP-1 is better than another GLP-1. And they say someone, whether it's me or another one, and obviously it's not better or worse. Everything is situational and individualized. But they will go out and buy for cash, more than $1,000 a month for a month or two, even before they see me. And then by the time they get to clinic, they've already spent $4,000 on this medication because they think maybe it would be better for them, where there could be a perfectly fine alternative that happens to be covered on their plan. It just happens to be from the competing pharmaceutical company.
Yeah, I think that's why discussing with your physician and getting really specific, individualized recommendations for you and your priorities and your price range and everything like that is really important.
So I guess we briefly discussed rosuvastatin and atorvastatin. We discussed how some people, even though they're both generics and they've both been statins for a long time, one's lipophilic, one's hydrophilic. Sometimes they're called lipophilic and non-lipophilic. But some people have been messaging me about David Sinclair's recent tweet. We actually talked about this on the After Hours podcast of all podcasts. We try to do entertainment, but we went into this. So we'll link that either above or in the description for people that are curious. But as a non-clinician, non-scientist, for people that are listening to this, how do you read a tweet like that? I think it's somewhat alarmist. Specifically calling out something like rosuvastatin as being more concerning for dementia or whatnot. How do you interpret that?
So I interpret that as it is, a single study that is showing one result, and there are limitations and biases to every single study. And so it needs to be taken with a grain of salt and compared to the majority of evidence that exists out there. That study specifically was really interesting that was the conclusion that he came to, because it actually mentioned 3 different studies, and in 2 of the studies there was no difference, and then he chose to discuss the one study that there was a difference. And then on top of that, I think it was a 3-part tweet, and the 2 subtweets were unrelated to that study, and they were meta-analyses that looked at the overall, all the studies that are looking at this, and develop and weight those based on how good the evidence is and how much bias there is, and then comes up with a single point to look at the statistical significance of that. And those studies compared all statins with dementia risk and Alzheimer's risk. So that is how I interpret a study. I would look at that one study, but then the next step I would go is I would search for meta-analyses. If not that, I would look at systematic reviews. If not that, I look at pooled analysis. And so all 3 of those things are looking at the majority of the studies out there that exists and the general direction of where it's pointing. And we oftentimes update the medical literature. We think one thing and we learn something new, and it changes our mind.
Mhm.
But usually the direction that the majority of studies are pointing, that does not flip back and forth.
Mhm.
So the majority of the studies are showing that the statins decrease the risk of Alzheimer's and general dementia. And so that's kind of where I would lay the most of my confidence.
Yeah. Another thing to think about is observer bias. So if you're looking at the lifetime incidence of something like neurodegenerative disease, and some studies do account for these confounding variables, at least to the best of their ability. But if in the case of something like a metformin or a statin or even a GLP-1, let's say it's a diabetic patient, and let's say if they didn't start one of these medications, again, back to that all-cause mortality, maybe they would live 1 year longer, an average of 80 years to 81 years. So the incidence of neurodegenerative disease in those individuals between age 80 and 81, you would find that in one group, but not in the other group.
Yeah, and I think we're throwing around some terms here. So just to kind of point out some key words here so everybody is understanding. Confounding is when there's an association between a predictor and an outcome, but there's another predictor that also could be involved. So I like to think, or what I learned in medical school was there's an association between having a lighter in your pocket and lung cancer. But there's no biological link between those things. But having a lighter in your pocket is associated with smoking, and that is associated with lung cancer.
Mhm.
And so that is a confounder. And so in every single study, there is going to be confounding predictor variables that you need to account for. And some of those you can account for and adjust for, and some of those you just can't account for.
Mhm.
So usually if the authors are good, they'll include that in the discussion as a limitation, but not all the time.
Mhm.
And then we're talking about bias a lot as well. And bias is a word that is used colloquially a lot, but in medical literature has a very specific definition.
Mhm.
It's changing the sample population, so the population that you're using for the study, and how that is different than the overall population. So you might have a selection bias where the people that are included in your study chose to be in that study, and therefore might be a little more health conscious than the general population. And so that's a bias that changes the outcome and how it can be applied to the general population.
One fun example of selection bias is studies that administer 500 milligrams of testosterone cypionate per week to healthy male volunteers in their 20s. So you will certainly have a selection bias of healthy males in their 20s that are willing to have 500 milligrams a week of testosterone administered. Perhaps slightly less healthy males in the 20s that would be assigned to a group of placebo, 50 milligrams a week, 100 milligrams a week, or 500 milligrams a week. But I thought that's a fun example. Another example of correlation versus causation, and as far as like confounding variable, is polygenic risk scores. So in general, I'm not a fan of polygenic risk scores. Eventually they will inevitably get better and better.
Definitely.
But, and I think James has talked about this a lot as well, so I won't totally steal his thunder. But one interesting one that I've seen in one of the reports is, in what percentile are you for your genetics, for your average age of first sexual intercourse? So you think, well, what does that have to do with genetics? Isn't that mostly nurture and not nature? So is that related to, how you look? If you're generally more genetically attractive or unattractive, or perhaps, and this is one that is likely more than just correlation, age of puberty. So like age of sexual development would hopefully be somewhat related to age of first sexual intercourse as well. So I thought that was a particularly odd example of something to look at in genetics.
Yeah, I think we need to be really careful with some of the terms we use in precision medicine. This is a big field that is developing and that has really exciting future in the next few decades as our genetics improves and our screening improves. But this idea of percentile and where you are, I think, needs to be really taken with a grain of salt. This is a statistical measurement of where you are compared to the normal population. And this assumes a normal distribution, a normal bell curve, which certainly is not the case for every single disease. There might be right skew, which means there's a lot more people on the upper end. And so that kind of 1% is really extreme compared to the median. compared to a normal distribution, which it might be closer. So there are some big limitations with these, and we need to be. That's why it needs to come in conjunction with counseling with your physician.
Yeah. On the tier list of functional medicine or precision medicine interventions and diagnostics, these would probably be C tier or F tier. We should put together a tier, like an actual tier list.
I think that'd be really helpful. That would be fun.
So functional medicine is supposed to be root cause medicine to describe it. So things like LP(a) or ApoB, those would certainly be A tier, or is it an S tier? That's the highest strong.
Yeah, S tier is the top.
Yeah, so S tier at the top would be LP(a), ApoB, perhaps at the bottom. And even if it's a F tier at the bottom, it doesn't mean it's worthless. But you have to put in things like SNP testing outside of your high yield SNPs, like nutrigenomics, or maybe even organic acid tests, just because some people get them on literally everybody. Maybe C tier, a bit higher, cookie cutter stool microbiome mapping tests, just like for literally everybody. And I've done other podcasts before as well. I did the Genova podcast, and stool microbiome mapping is helpful. But one of the analogies I make is it's like testing the exhaust that comes out of your car. It tells you a decent amount about your engine function and like what fuel you're putting into it and what's actually in the chamber, but a bit less. Maybe we'll do a separate thing just on the tier list of precision medicine and functional medicine interventions.
I think that'd be great. I think that'd be a lot of fun and provide some good value. I think that's also a good reason why there's some kind of resource guarding and can be interpreted as gatekeeping in medicine, where you as a patient are not able to just go and get any sort of testing that you want. A lot of it needs to be prescribed by a physician, because if you just do all those and don't have it tiered and don't understand kind of the pathophysiology behind those tests, then you could get an F tier test and think it has the same validity as an S tier test, and that's certainly not the case. And so that's why it's important to discuss this with someone with a good amount of experience and understanding to kind of help you differentiate those and what they mean and how they can be interpreted.
So should I or shouldn't I go get my full body MRI without the supervision of any physician to see every tiny little calcification or potential tumor or cyst that's in my lung and liver and colon?
You should not. You will find incidental findings and you will get stuck in the medical system. You'll be biopsying all these things. And there's probably not much of an impact, a benefit to you. One thing coming to mind is thyroid nodules. How many thyroid nodules do we find that are incidental findings, and they cause a lot of fear? They cause unnecessary testing, and that's of course associated with increased cost, as well as some complications, which could end you up with a serious complication later, a serious problem later on that you didn't even need in the first place.
And this is where the balanced approach to health comes into play, because we are a fan of full body MRI testing. In fact, there's a company called Preventive that we order on many patients and also that we specifically don't order in some patients after a rigorous process of shared decision making and good physician-patient rapport, and understanding that, yes, and this is the way I see it. This is kind of like my elevator pitch for it. Expect to do multiple, because you will find those calcifications from a respiratory infection you had, or from the trekking that you did in Nepal a long time ago. You will probably have some hepatic cysts and whatnot from when you had, intamoeba or whatever other weird diseases you may have picked up. But you won't really know if that's truly due to that until you get your follow-up scan in a year or 2 years or whatever the recommended interval is. And then in between all of that time, maybe you call it health anxiety. It is not a zero harm test, but it can certainly hugely benefit some people who are able to get it with proper supervision.
Absolutely. And that's a great example of something it's going to be really hard to convince your provider to give you in a normal traditional health system. And why I'm really enjoying working at Gillett Health, and I think I can provide very high quality care for my patients, is because we have the ability to do these things and trend them over time.
I think that's a pretty good summary. It always kind of seems to come back to a balanced approach and individualized and talking with the patient about their goals. So regardless of if it's on the preventive medicine scope or on the health optimization scope, it kind of converges to that.
I think so, yes. A lot of overlap.
Well, thank you for joining us. I'm sure that we will do many podcasts together in the future. As always, thank you for your time, and may God bless you with health and happiness.